Okay, I'm going to try to be less boring, I promise you, with this talk. More clinical. And again, please feel free to stop me and let's have some interactive conversation about this. So now that we understood all the basic concepts behind heart failure, let's look into the acute heart failure syndromes. And I have even more ambitious agenda to cover here, but we'll go quick. We'll talk about epidemiology, some definitions, a little bit on pathophysiology that is pertinent to acute heart failure. But really heavily emphasize the diagnostic and therapeutic approaches to acute heart failure. A couple of slides on cardiorenal syndrome, and mostly in terms of practical management. If I have time, I'll show you a couple of slides on new treatments that are on the horizon. And then some things that we can do before we discharge the patient to prevent readmission. So if you look at the rate of hospitalization for any condition over the past 30 or 40 years, you will see that it's actually plateauing or coming down. So we have been doing really good job in reducing hospitalizations. Of course, some of you on, who been on call the last couple of days may disagree with me, but generally speaking, we are seeing more outpatient care, less inpatient treatment. That is actually not true, however, in heart failure. I showed you that slide earlier. Hospitalizations for heart failure are on the rise, and it's an endemic. And it's costly. This is an outdated slide. It says that the cost of hospital care for heart failure is about $15 billion. It's actually more on the range of $25 to $30 billion. None of this money we're seeing, obviously, but it's very costly condition, and that's why hospital administrators are now very interested in doing something about heart failure and reduce the 30-day readmission, because there's a penalty now for hospitals who have unacceptable readmission rates. So throw some numbers to kind of show the burden of acute heart failure. The median length of stay is 6 days, and that's in the United States. If you look at the average length of stay in Europe, for example, it's probably about 14 days. I say, why don't we keep them 29 days? And this way we can cut on the 30-day readmission rate. That's a joke. All right. Now, quarter of your patient that you sent for heart failure come back within 30 days. So 1 out of 4 coming back within 30 days. 5 out of 10 coming back in 6 months. Now, I mentioned to you that 1/3 of your patient with acute heart failure will die within 1 year. It's definitely worse than breast cancer, worse than colon cancer. Contrast that to annual mortality rate in chronic heart failure, which is 7% or 8%. Now, these numbers are not just national numbers. I mean, we have high burden of heart failure in North Carolina, certainly in eastern North Carolina. I don't know what you're going to call this belt. I mean, you can call it the stroke belt, the salt belt, the Bojangles belt, whatever you want to call it. But, we sit in this very dark shaded area with lots of death from heart failure and cardiovascular disease in general. If you break it down by the hospitals that we get patients from, you see that bigger hospitals that see sicker patients have higher readmission rate. In fact, the whole business of readmission, 30-day readmission rate is actually bad science. It's all arbitrary benchmark, not based on any clinical or scientific merit or data. I actually argue that if you have good access to care, solid heart failure service, your readmission rate should go up because you keep patients living longer. In fact, all these readmission rates do not adjust for mortality. So hospitals are penalized for keeping patients alive. So if I reduce your readmission, I'm bad, but if I kill you, I'm good. And you see how passionate I am about this because I deal with this on a daily basis with administration because they judge us in terms of how many patients we keep out of the hospital within 30 days. But that is not adjusted for disease severity or worse for mortality. This is changing. There's a trend. There's actually a movement now towards adjusting readmission for mortality. Now, I can also break down the numbers of readmission by services. I actually have lots of slides that I can break down by services, wards, the name of the doctor. I'm just kidding. I don't have the names. I don't have the names. I have the name of your attendings, but not you. But we know what section of the hospital doing better than other sections, and I'm sure you know too. So what is acute heart failure? Well, it's simply a new onset or gradual or rapidly worsening heart failure, signs and symptoms that require urgent therapy. Yes, sir. Oh, I wanted to just glance over there. All right, I'll do that. Yes. Yeah. Yes. Well, I look at it this way. I understand that. But I look at it this way. About more than 1/3 of it coming from the academic section, right? So ECU, family medicine, internal medicine. You guys are doing very good. I didn't want to highlight that, but you guys are doing good, 11%. But doing good in what? You're doing good in not getting heart failure. I'm just kidding. I mean, this is not the readmission. This is not the readmission. This is just where heart failure is ending up. I'm not going to show you that. I will not show you that. I have it. It's actually equally distributed. So I mean, it's equally distributed. All right. Any other questions on it? All right. Well, we don't have inpatient heart failure service, which is actually getting ready to change. And in fact, next week, I may be able to share some information with you on something very exciting that we're working on. And that may change, where we can actually take all these sick inpatient heart failure cases and just heavily, educate them and maybe do invasive monitoring, hemodynamic therapy, enroll them in the CHF clinic, so on and so forth. And that will be an opportunity for you guys to be involved as an elective, or if you're interested. But that's one deficiency of this hospital, that we don't have an inpatient heart failure service. And inpatient care has been scattered and not standardized. So going back to my classic slide on HFrEF and HFpEF, and the reason I put that again is to show you that how many. Okay, let me do a quick unsigned, quick poll here. How many of you would think that acute heart failure with preserved ejection fraction is prognostically better than acute systolic heart failure? Raise your arm. So if you have acute diastolic, what I'm trying to say, if you have acute diastolic heart failure, is it better than having acute systolic heart failure? Or about the same, or worse? Worse? Okay. Well, it's not worse, but it's not better. And it's important because, again, it goes back to this myth about ejection fraction. If your ejection fraction is low, then your heart failure is worse. And this is important. It's actually important even in my CHF clinic. I hear it all the time from when I go to the CHF clinic and they present to me patients and they tell me, well, this patient has preserved ejection fraction. I don't know why they send this patient here. And I actually scold them when I hear that, because heart failure with preserved ejection fraction is as bad as reduced ejection fraction. In fact, the 30-day readmission, coming back to the hospital, the percentage of patients who come back within 30 days for readmission, the percentage of patients who truly have heart failure is probably about 30 to 40%. And the rest, they have UTIs, they have falls, COPD exacerbation. And many patients who have preserved ejection fraction have all these comorbidities. So what I'm trying to say here is that the burden of readmission with preserved EF is actually higher than with systolic, because they have all these comorbidities. Is that clear? All right. Now, acute heart failure patient can have acute coronary syndrome or normal coronaries. It can be, again, preserved, it can be reduced. I put this slide up to alert you to the importance of ruling out ischemia as a precipitating factor of acute heart failure. Somehow we have been so obsessed with troponin in all patient population except in acute heart failure. And I think everyone is assuming that troponin, which is a good assumption and likely always true assumption, that troponin elevation in the setting of acute heart failure is more of a secondary elevation, is an LV stretch, is a subendocardial damage, it's a supply and demand mismatch rather than a plaque rupture. Therefore, troponin, yes, it confers high, poor prognosis, but it's not necessarily, something that you have to chase and do heart catheterization. Again, that may be true in majority of cases, but if your patient is having angina with this, then you really have to pursue that troponin and fix that left anterior descending artery that keeps bringing the patient back in the hospital. So quickly in pathophysiology, and I promise you this is just 1 or 2 slides on pathophysiology. Your cardiac index is low. I bored you to death on the increased vasopressin, RAS, activation of sympathetic system. All this lead to renal, sodium, and water retention. So you have volume overload state. And that is going to cause the ventricle to dilate, basically, and the interstitium of the heart to become wet, and the interaction between actin and myosin to go down. So you have dysfunctional, dilated and dysfunctional myocardium, which leads to mitral regurgitation and elevated filling pressures. All of that is going to lead to myocardial injury, and then the more injury you have, the more drop in cardiac performance, so on and so forth. So it's a state of vicious cycle, and you need to keep that in mind. Now, a couple of words on Starling Curve, and this is another essential concept that you need to understand in order to adequately decongest your patient. So in a normal heart, if you look at the preload or central venous pressure against cardiac output or performance or stroke volume, the relationship is really like a slingshot relationship. The more you stretch your fibers, the better the cardiac output, provided that you have good elasticity, provided you have good relaxation properties and compliance properties of the ventricle. So in normal states, a desired cardiac output on this horizontal line, if it is achieved at a low CVP, then your patient is dry and having no symptoms. And all of us in this room hopefully have this good, nice relationship. We have good cardiac output. We have good cardiac output from low filling pressure or starting pressure. That's the ideal state. Now, if you are dealing with a failing heart, you have drop in contractility, which leads to downward shift of the curve. So now, in order to achieve the same cardiac output, you really have to do it from a higher preload. Again, as simple as that. And that's why your patient's JVP is up. That's why they have RALs. That's why their X-rays are congested, because their filling pressures are congested. And they're doing this in order to preserve the cardiac output. Now, notice that on this curve, you can be here and you still have low cardiac output. And you can be here and you can have low cardiac output. So the sweet spot, ideally, you should be here. And that's why too much diuretics can bring your patient down here and you have low cardiac output and they do worse and their kidneys worsen. And if you leave them with really significant backward failure, then their cardiac output is low. So this is what we call the descending limb of Starling Curve. When they are way over there on their preload, you get to the point that you stretch that slingshot all the way back and you lost lots of force with that because the actin and myosin fibers are not interacting anymore. Is that clear, the Starling mechanism? Any questions on that? So what are the precipitating factors? You'll be surprised to learn that there is only one study that looked at what brings patients to the hospital most commonly, and that was in the mid-90s. And you probably won't be surprised to hear that the most common cause of hospitalization was non-adherence with therapy and diet. I argue, however, that it's not the most common cause of rehospitalization. It's convenient for us to blame this on the patient. And yes, granted, there are many barriers to care and health disparities, and yes, there are patients who are stubborn, and you take the, I heard all kind of analogies, the horse and the water, and you can't, all of that stuff. That's true, but some of it, sometimes it's hard to take clinicians to the water, so it really is a combination of that. But I think the most common cause of hospitalizations, I think the most common cause is progression of the underlying disease or lack of appropriate treatment. Having said that, these are the things that you need to look for. Rule out ischemia, infection as simple as UTI, again, patient not adherence to CPAP therapy, substance abuse. This is big, and I'm sure you see that all the time. It's big and it's problematic. One thing that is underappreciated is pulmonary embolism, and these patients don't necessarily exhibit the same clinical picture of pulmonary embolism in patients without heart failure. So don't look for hypoxia in these patients. They can have, and the reason for that is that you can have small PE that decompensates someone who has already poor cardiopulmonary reserve. All right, so keep that in mind. Now this is a fascinating slide because it shows you that when your patient hit the door in the emergency room, the patient actually has been working on the disease, the acute flare-up to maybe 2 or 3 weeks before they show up in the emergency room. And we know this because we now have implantable monitors that can actually measure impedance, intrathoracic impedance. So we know the total body volume, intra-chest volume, and we know we can actually look at the chronology of that. So why am I showing this slide? Well, it's simple. There is actually a window of opportunity where we can intervene a week before, or 2 weeks before the hospitalization and do something. There is something called clinical congestion or clinical congestion or congestion that manifests, that you see with the clinical signs and symptoms, and there is hemodynamic congestion. This is clinical congestion, it's manifesting. This is hemodynamic congestion. It's like genotype and phenotype, and really we have limited ways to assess that hemodynamic congestion. But still, if you monitor the weight, if you monitor the symptoms, you will be able to tease this out and maybe augment your patient diuretics and prevent hospitalization. How about the sensitivity and the specificity of the signs and symptoms that we have? We talk about JVP and ROUSE and edema and S3 gallop, and for those of you who come through the CHF clinic, we can show you the JVP and how to assess it, and it's actually very interesting, very neat, and it's very helpful. The problem, however, is, and you don't have to read the whole slide, but I can tell you that although the specificity of all these findings is actually good, ranging between 70 to 80 to 99% when you have tachycardia specific, but it's not sensitive. So if you don't hear ROUSE, it doesn't mean that you don't have acutely elevated pulmonary filling pressures. If you don't hear S3 gallop, it doesn't mean that you don't have acute heart failure, so on and so forth. So the sensitivity is poor. And anyone knows why you can have acute heart failure and not have ROUSE when you listen? Good. So the lymphatic system is very elaborate, and it takes, basically it drains the interstitium very effectively. So keep that in mind. Important to do your examination, but very, very tricky. Now, this is a complicated study, but let me give you the take-home message with this study. When we look at JVP, we are assessing the right atrial pressure. Basically, we are getting an idea about systemic venous pressure. JVP is not telling me anything directly about pulmonary pressures. It doesn't tell me anything directly about the wedge or the preload. But we're assuming that there is concordance between the right side and the left side, meaning that if the CVP is high, then the wedge is going to be high and vice versa. Now this study just looked at that to see what is the rate of concordance and what is the rate of discordance. And it found that majority of times, there's good linear relationship concordance, but then there are outliers. And in about 20% of times, you can have elevated JVP, but then your wedge is low. And about 20% of times, you can have normal JVP and wedge is high. And I think that latter finding is very important for you to recognize. And the teaching point here is that if you have someone with suspected heart failure, and I'm not looking at BNP yet, we'll get to that in a minute, and you look at the patient's neck and you don't see dilated veins, that doesn't mean that they don't have heart failure. Just keep that in mind. Okay? In 20 to 25% of times, they can still have elevated wedge and you don't see it. Now, furthermore, keep in mind that, and I mentioned that earlier, when we look at JVP, we're assessing right atrial pressure. But we're really not interested in the right atrial pressure. We're interested in the LV and diastolic pressure. That's the preload that I showed you on Starling Curve. If it's high, then you have acute heart failure. So there are lots of assumptions that go between the right atrium and the left ventricle. So keep that in mind. I put this slide there to tell you, don't blindly believe the JVP if it is absent or if it's present. Furthermore, and the last slide on this concept, remember, when we look at JVP, we are assessing pressures. We're not assessing volumes. The gold standard for figuring out if your patient is truly volume overloaded is to tag his or her red blood cells, with nuclear material and measure the body volume. They do that in certain dialysis centers, and it's not very expensive equipment, but it hasn't picked up, and nobody uses it, and of course it's cumbersome. So we look at JVP, and I can show you here that you can have elevated wedge. You can have a wedge of 20 here, and with normal compliance of the ventricle, it tells you that the LV volume is increased. So that's concordance. That's linear relationship. Wedge is high, pressure is high, JVP is up, then the volume is up. But then I can show you this patient who is an 85-year-old patient who has long-standing hypertension, very thick ventricle, very non-compliant and stiff. And actually, the volume is normal, or even low volume. But then the pressure is high. But guess what? We're looking at wedge, and we're looking at JVP, and we're giving diuretic therapy to this patient, and actually hurting the kidneys because we're lowering blood pressure. So the same wedge pressure with different volume status. Now, I show this not to confuse you, and just every time you look at JVP now, you're going to be confused. I actually go through this all the time. I get confused sometimes. I look at JVP and I get kind of confused. Is this true JVP or not? But then sometimes you have to be reductionist. You have to just believe the data and just go from there. But it's more to it than that. And I think that's the last point I make. I think it becomes important to question yourself about pressure-volume relationship and JVP, total body volume relationship, when your patient is not doing well. Meaning, when you are diuresing someone with JVP and then all of a sudden you see that the patient is not doing well, actually doing worse. Then you can say, well, maybe that JVP is a tricuspid regurgitation that I see. Or maybe it is a very stiff RV that's causing the right atrium to be stiff, and so on and so forth. Is that clear? Any questions on that? All right, so the BNP, everybody loves that. Anyone from the emergency room here? Good. So the BNP is, stop it. Okay. So BNP is a great test. It's the SED rate for heart failure because it has very good negative predictive value. If you have someone with a BNP of 10, if you have someone with SED rate of 5, they don't have osteomyelitis. If you have someone with SED rate of 20, I don't know if they have osteomyelitis or not. If it is 150, they probably do have it. So see, at the extreme of the level, it has very good diagnostic power. But when it's in between, But more importantly, when it comes to BNP, is trending it, is knowing what your wet BNP, what is your dry BNP. That's why I encourage you to check BNP on the day of discharge. Your patient is leaving home. This is the time that you think they're the driest. Go ahead and check a BNP, and that will serve as a reference for future. The same when they come in. That's your BNP, that's your wet BNP. Now, as far as tracking it, and seeing if you do it every day, that you will make a difference, the data is lacking. It's not in the guidelines, so I wouldn't recommend it. But, it can be helpful. Your BNP level on discharge should definitely be at least 50% lower than your admission BNP. If you don't have a baseline BNP level, then you can hopefully send your patient with a BNP less than 350 or 400. And this study looked at that and showed that if you use that strategy, you can actually make improve outcome. Finally, there are too many nuances to BNP, too many nuances. And I'm sure that all of you know this, that obese patients don't necessarily have the same level of BNP for the same level of filling pressure or severity of heart failure, if you will. There's no magic conversion rule. Some people say, if you're above 200 pounds, then you have to multiply your BNP by 2 or 2.5. But now, pro-BNP, which we don't check here in this hospital, but sometimes we get patients from outside the hospital with pro-BNP. Pro-BNP should not be affected by obesity, so keep that in mind. Pro-BNP and BNP will be affected by GFR, so can be elevated just simply because your creatinine clearance is low. And then finally, the BNP has a half-life of what? 20 minutes. So your BNP test is only good for the time that the nurse got the specimen, and after that, so when you walk to see the patient, that BNP that you saw a couple of hours ago is not the BNP that the patient has right now. Now, there's a steady state. Obviously, they probably have the same BNP, but just keep that in mind, and that becomes important, in patients who have acute diastolic flash pulmonary edema. They can have a normal BNP, and they had a BNP of 2,000 an hour ago, and then they're fine now after oxygen and diuretic therapy. We'll spend 2 minutes on this, and we're almost done. This is the Lynn Stevenson model that everyone should understand and should get that paper. Search PubMed for Lynn Stevenson and heart failure model, and it really is a good way to link your signs and symptoms of congestion with signs and symptoms of perfusion, and do this on every patient every day and document that, because it has implications in terms of what is your next step therapeutically speaking. So what are the things that we look at for congestion? We look at RALs, orthopnea, JVP, lower extremity edema, ascites. Things that we look at for low perfusion, altered mental status, narrow pulse pressure, worsening renal function, hyponatremia, all of these things. So see, all bedside assessment. You don't need a SWAN, you don't need an echo, and you can look at that, the profile, and obviously the ideal one is the warm and dry. You have no congestion at rest and no low perfusion. So you're warm and dry, and that's the home profile. Now, fortunately, 80% of patients who come in with acute heart failure have the so-called warm and wet profile, or profile B, where they have elevated filling pressures, their preload is high, but then their cardiac output is normal. And these are the patients that will do well with just diuretic therapy. Less commonly, and that's the patient that you see in the CIU. You're not going to see in the intensive care unit. Less commonly, a patient who comes in with wet and cold profile, can't breathe, and then blood pressure is 70. So what do you do with this patient? And then, of course, very rarely that you see someone that you actually is way down on the Starling Curve. I showed you, remember the Starling Curve, you can be up there, but you can be all the way down here with a low preload. and that will result in dry state and cold, low perfusion clinical manifestation. Any question on this? All right. So therapeutic options, diuretic therapy is the key for management of acute heart failure. You're simply reducing fluid, you're reducing mitral regurgitation, you are bringing your patient back up on the Starling curve, and you're actually improving cardiac mechanics that way. Rarely that we need to use vasodilators to reduce preload, and then sometimes if your patient is wet and cold, you have to warm them up before you dry them out. So you have to give them inotropic therapy. Just quickly to go through the next few slides, and I think that will be the last few slides that I have. But if you give a patient 80 milligram of IV Lasix, you're going to make them feel better. They're going to put out a liter of urine. But notice what's going to happen to their GFR. It's going to go down. Now, that may not be clinically significant. And more importantly, it may not be because you actually removed volume and you created pre-renal state. It's actually because diuretics, certainly loop diuretics, may have a direct effect on the renal tubule, like toxic effect on the renal tubule. Has to do with tubulo-glomerular feedback mechanism and vasoconstriction. So it is true that diuretic therapy can hurt patients in acute heart failure. And I put that slide there to demonstrate that. However, I argue that diuretic therapy, most of the time, majority of times, will help your patient. And it is underutilized, and the doses are smaller than should be. And the patient are being sent home before adequately diuresed because of fears of this phenomenon. And this slide will show you how actually diuretic therapy can improve cardiac function. It can improve contractility. And I've already shown you the Starling curve, and I showed you that if you are way up there on the descending limb, your cardiac output has dropped. If you bring your patient back up, your cardiac output goes up. As simple as that. So remove volume, improve cardiac output. Reduce mitral regurgitation, reduce backward failure, then you improve the forward failure. And then finally, when you are draining water out of the interstitium of the myocardium, you're actually allowing for better interaction between actin and myosin. So you have better cardiac mechanics and improved cardiac output. So I always joke and say that diuretic therapy is actually the best inotropic therapy there is, provided that your patient is starting from a very high preload and he or she is on the descending limb of Starling curve. Is that clear too? All right. Now, in chronic kidney disease, if you look at the efficacy of diuresis compared to normal subjects, you see that there is actually a secretory defect in these patients. Therefore, their response is less or suboptimal. And the way to overcome that is by giving more furosemide to achieve the same level of diuresis. So we're measuring how much we diurese with FeNA by how much we gave to diurese that patient. And in normal subjects, this is the curve. In patients with chronic kidney disease, we're unable to get the furosemide inside the tubule, so we have a secretory defect. Therefore, we have to give higher doses. Now, in heart failure, we have that, but we also have something called decreased maximal response, meaning that you can give as much diuretic therapy that you want to give, and there is a threshold above which, below which, you're not going to be able to achieve the same response as normal subject. Again, no one knows for sure what's causing that. It could be vasoconstriction or other mechanisms. Therefore, the way to overcome that is by giving smaller doses but more frequently. So you're exposing the tubule to more of the diuretics rather than concentration, but actually exposure. Now, the loop diuretics work on the ascending loop of Henle, and what you're doing here is you're preventing reabsorption of sodium. So every time you give your patient Lasix, you are depleting their sodium and delivering it to the distal tubule. And that's the mechanism behind true diuretic resistance. Because when for months or years the distal tubule has been exposed to high load, high sodium load, the cell is going to hypertrophy and become more efficient at reabsorbing sodium. So now everything that you're getting rid of upstream is being reabsorbed downstream, and you're in that vicious cycle. You know, the more loop diuretics you give, the less response, and that's when you pull out your distal tubular diuretic, you know, such as metolazone, and that combination is actually powerful. Again, provided that your patient is truly diuretic resistant. This is a study that looked at continuous infusion versus intermittent bolusing. And the conclusion was that there's no difference between the two approaches. However, this study has been quoted extensively in the last 2-3 years. You know, it is actually not the end of the concept of continuous infusion, because the study did not select the appropriate patient that would potentially benefit from continuous infusion. In other words, the study had less sick patients that we typically want to escalate therapy with continuous infusion. So just because this study is published in New England Journal of Medicine doesn't mean that we don't use continuous infusion. Yeah, so inotropic therapy, again, you really need to be careful not to use it except if you have a patient with wet and cold profile or a patient who is on the verge of cardiogenic shock. You know, different inotropes, different vasopressors have different properties, and you need to understand that. You cannot use vasopressor therapy to treat acute heart failure because you will increase afterload that way. You always start with an inotropic agent, such as the butamine or mirinone. And if your blood pressure is dropping, then you can add small dose vasopressor. But you need to keep this card in your pocket and figure out the physiology of every inotropic agent that there is, and use it appropriately according to the physiology of shock state that you have. When inotropic therapy has been studied, it was shown to actually increase mortality because it taps into the myocardial reserve. It causes arrhythmias and tachyphylaxis, and obviously you cannot use it in patients who have who are treated with beta blockers, unless you're using mirinone, which works on a different pathway. Now, this is a summary of when I would use inotropic therapy. If your patient has elevated filling pressures, low perfusion state, if you are pushing diuretic therapy and then faced with worsening renal function, then that is something to consider, provided that you have hemodynamically monitored your patient and know what agent to use. Impending cardiogenic shock, patients who have end-stage heart failure and you're preparing them for advanced heart failure therapies such as transplant and mechanical support. And again, you almost always have to have a PA catheter in place so you know your targets. This is a summary slide. Time is up, right? 5 more minutes? Okay, so this is a summary slide trying to kind of simplify the process of care for acute decompensated heart failure. Almost always, in about 75 to 80% of times, you can bail patients out by giving IV diuretic therapy and oxygen, and that is usually accomplished in the emergency room. If you have a patient who had inadequate response, and the definition of inadequate response is urine output that is less than 500 cc within the first 1 to 2 hours. If your patient is not putting out 500 cc and or they're still dyspneic at rest, then this is inadequate response. And this is when I would reach for a vasodilator agent such as nitroglycerin or nitroprusside if provided they have adequate blood pressure. If that is inadequate, meaning they still remain symptomatic, they have worsening renal function, urine output is not improving, then you escalate therapy. And by that I mean you take them from 3Es to CIU, or from CIU to CICU, and you have hemodynamic monitoring in place. You figure out their filling pressures and their cardiac output, and then you decide if they need inotropic therapy or not. If they don't need inotropic therapy, and you can just bail them out by augmenting their diuretic therapy by using continuous infusion or mechanical ultrafiltration, then that's fine. But then if they progress and they decompensate further, then you need to escalate further, which is something that can be done in the cath lab by inserting percutaneous support, or even surgically inserted mechanical support towards transplant. So see, it's a stepwise approach, starting from the simple, most common therapies, all the way to sophisticated advanced surgical treatments that we have. Just a couple of words on cardiorenal syndrome, and unfortunately we're not going to have time to cover the last two items. But with cardiorenal syndrome, the problem here is that even the slight rise in creatinine confers increased mortality. So even if your creatinine goes from 1.2 to 1.4 or 1.5, your patient outcome is worse than if it remained the same. So that is problematic, and it needs to be addressed. And typically, and again, I showed you in the first topic that the conventional wisdom has been that you reach out for your inotropic agent, you warm your patient up, and your creatinine is going to improve. But unfortunately, that's not always the case, and it's all about renal perfusion pressure. If you are unable to improve that net filtration pressure by improving the arterial filling and reducing the venous side, then you haven't accomplished improvement in renal function. So the next step when your patient's creatinine rise is to go back and look at the physical exam, and if they have JVP and the BNP has been rising and they're still edematous, you need to escalate your diuretic therapy, whether it's giving intermittent bolusing 3 times a day rather than twice a day, or actually switch to continuous infusion, or if the patient is already being continuously infused, then you proceed to ultrafiltration. If your creatinine continues to rise, that's when you put a catheter in place, and then you consider inotropic therapy. Is that clear? How you approach cardiorenal syndrome? So now you understand the mechanisms, the pathophysiology behind it, and then if you encounter it, that it's an indication for escalation of treatment. Business is not unusual anymore, and you really have to go to next step. All right. So I'm going to stop right here. I bored you enough, 2 topics back to back, I know, but this is just meant to stimulate your interest. And if you guys have any questions, welcome to talk to me anytime. Thank you.
We'll take a 5-minute break, but you can ask questions